we officially call the House to order. So good evening, distinguished colleagues, and welcome to tonight's SPEAR webinar brought to you as a premier educational initiative by Sun Pharma in collaboration, of course, with Kenya Pharmaceutical Association, Coast Branch. As I've just said, my name is Dennis, your colleague, a pharmaceutical technologist, and it's my absolute privilege to guide us through tonight's vital clinical discourse. So, of course, members, every single day across our community pharmacies, outpatient clinics, and hospital wards here in Kenya, respiratory tract infections and urinary tract infection makes up a vast majority of patient presentations in the race to provide rapid relief in the pressure to dispense or prescribe broad-spectrum antibiotics is immense. So, however, we stand at a clinical crossroad where global antimicrobial resistance threatens to outpace our therapeutic options. So tonight, we will dive deep into the topic that directly safeguards our future in prescribing power of antibiotics, stewardship in RTIs and UTIs infection management. So before we kickstart into this edition, I would want us to type in the chat box. Let me know where you're joining us from. I want to know where you're joining us from. So tell me your facility. Which facility are you representing from? Where are you catching us from? So let me see in the chat section. Feel free to type. Inango Pharmacy, Kwale County, thank you so much. So continue telling us where you're joining us from. Bristol Park Hospital in Kitengela, that's very good. I see you, Nicholas Ogola from Ikoni, Joanne from Kilifi, Cynthia from Nairobi, Matata Hospital in Homa Bay, Philip Muita, thank you so much. Keegan, Makueni County, Mombasa County is locked. Paul Adams, Border Police Hospital in Kanyonyo, I see you. Alupe Busia, Kisiangani David Rurale, I see you. Sandra Haemba, Kitui County, Korir, Egerton University, Sanatorium, Nairobi, Jace Pharmaceutical. So guys, clearly from the look of it, I can see that we are all represented tonight across the country. So all facilities across the country are actually represented tonight. So as I've just said, today's session is going to be a very interactive session as we've always done. So tonight being our 6th webinar, as we've always been doing this again in our series with SPEAR, it's not going to be any different. So tonight's session also, we promise you that we are going to have goodies, of course, as we always do it. The top 5 members who will be answering our question fastest in the chat box, we will be awarding you awards, of course. And as you know by now, we've done this like 3 times. We live true to our word. So that is something which we are going to make sure that we do. So without further ado, allow me to take this opportunity to welcome Mr. Rogers Kanja, Chairman Coast Branch. Please welcome, take this opportunity to introduce us to your team, and also you can also comment about the CPD being on the portal and anything of the sort. So karibu sana, Rogers.
Thank you so much, our moderator. Good evening, honorable colleagues, members, distinguished learners. It's a great pleasure to welcome you to our Sun Pharma series of webinars. And today we are privileged to learn more about the upper respiratory tract and urinary tract. I wish everyone a wonderful session. And without much ado, allow me to welcome my fellow branch executive, Coast Branch leadership on board to say hi to members and to wish us a wonderful learning. Thank you so much, and I wish everyone all the best. My secretary and other executive members from Coast Branch on SMAS, please.
Good evening, members. My name is Rachel Mambori Mkombola. I'm the organizing secretary, Coast Branch. Thank you for creating this time for us. We are here to learn and we appreciate the support.
Good evening, everyone. My name is Onesimus Kavo. I'm the branch secretary, KPA Coast Branch, and I want to welcome every one of us to this learning session tonight. We dive into a very sensitive learning area, and I'm sure at the end of band to become AMS antimicrobial stewardship ambassadors across our areas of practice, because learning must be tested by improvement of our deliverables in the professional space. I want to highlight the aspect of this being a CPD accredited event. It will be uploaded anytime. The Pharmacy and Poisons Board tonight they will be sending their signature of approval on the event. Then after that, we have 7 days to claim our CPD tokens. So I pray that every one of us will be able to subscribe to the event so that we may not have challenges of people attending and missing out on the CPD points. Otherwise, we are looking forward to a very industrious learning opportunity tonight. Let us take our ways from the study. God bless you and feel most welcome. Thank you.
Okay, thank you so much. Thank you so much. So I think having heard from the Coast Branch officials, we highly appreciate that communication. So at this juncture, I think we will go straight ahead and proceed to do a recap on the question. Actually, members, this is the moment whereby the first 5 members who are going to answer my question tonight, we will get an opportunity to award you at the end of our session tonight. So I will actually ask James. James from Sun Pharma, please, can you kindly bring up my first question on the screen? We want to do a recap on what we learned on our last SPEAR session. So bring it on my screen so that I can ask members about it. So members, once the question comes on the screen, the top 5 members who answer it correctly will have an opportunity to actually win a token. So the question will be on my screen in the next few. So top 5 winners will be receiving 250 shillings airtime, which will be sent tomorrow in the morning. So please roll to the question, please, James. Thank you so much. So here comes the question. What is the esomeprazole brand for Sun Pharma? I'll repeat the question again. What is the esomeprazole brand for Sun Pharma? So let those answers continue coming. I see you guys. I can see how quick you are. Thank you, Dickens, Vane, Rurale, Brian, Barnabas, Cynthia, Sompras. Sompras is actually winning. Stephen, Ahmed, Jeremiah, Hosea, Dennis Magut, Christine, Ann Kiguro, Lucy, Robert, I see you, Lydia Mungara, Jane, thank you so much. Clearly, we were all very attentive and paying attention during the last webinar which we had, and actually that actually goes to the sponsors and everyone who actually organizes these sessions. It means that members always love these sessions and they're always ready to learn. Thank you so much, guys. I see your answers. So the correct 5 answers will be picked, and at the end of the session, together with other questions which we'll be asking, will be awarded by the end of the session. So thank you so much. So at this juncture, allow me to welcome James Mbogo. James Mbogo, I want to give you an opportunity to say hi to members and also to welcome us as the host. Say something, talk to us a little bit. Then I'll be able to take the mic and introduce the speaker for tonight. So James, karibu sana.
Okay, thank you, Dennis. I hope I'm audible enough.
You are audible.
Thank you very much. And I want to take this opportunity to just appreciate everyone who joined this meeting for creating time to join this session. I know it's at the tail end of the day. You are tired since morning, but you picked to join this meeting. As Dennis has said, the topic is actually something that is very close to our heart. Remember, the pharmacist, you are the pharmacy. You are the primary point of contact for, let's say, 99% of the patient. And if we don't do things correctly, we will end up, the whole community will suffer. So I really take this opportunity to thank you on behalf of Sun Pharma for just coming to join the meeting. So my name is James Mbogo. I am the product manager in Sun Pharma, in charge of Ranferon enhancing and the CNS brands. Dennis?
Thank you so much, James. That is well put. So, members, we want to now get to the next session. Today's session actually will be, as we've told you now, we'll be breaking some questions in between, which we will be expecting you guys to answer, and we will also be awarding you on the same. So after introducing the speaker will do the presentation. From there, we will get to product presentation from Sun Pharma. Then we do the Q&A, and then we will actually be able to award winners, then finish the session. That's actually how the order of events will run. So to help us navigate the first line between clinical urgency and rational prescribing, we are honored to have an exceptional frontline clinical expert leading our masterclass tonight. Our guest speaker is Dr. Hilary Edalia, who is a distinguished family physician at the Aga Khan University Hospital, balancing institutional guidelines with specialized patient-centered care. He manages the realities of complex infections, diagnostic dilemmas, and stewardship barriers on a daily basis. He is uniquely equipped to sharpen our clinical interventions and elevate our pharmaceutical care framework. So Dr. Edalia, the pharmaceutical fraternity across the country, across the 47 counties of this country, is fully locked in and eager to learn from your wealth of expertise. I now want to take this humble opportunity to hand over the floor to you to lead us in this masterclass of an event. Karibu sana daktari, we are very eager and hungry to learn. Karibu sana, the floor is yours.
Thank you, Dennis. Thank you so much. When I was actually invited, you told me I'd only be talking to 200 people. I can see you're already at 8. We're actually going to 900 now. You're making me a bit shy. Okay. So good evening to the team. Dennis, would you allow me to share my slides?
Kindly proceed, Daktari. Perfect. We can now see your slide, Daktari.
You can see the slides and you can hear my lovely voice.
Yes, we can see, and you are very audible. Proceed.
Okay. So just to start, and something we should appreciate is that antibiotic stewardship has been there for the last 70 years, and it has been evolving over those years. And want to attribute it to the father of antibiotics, Alexander Fleming, who discovered penicillin. And he actually, for lack of a better term, he foresaw a dilemma right now in the 21st century, where he mentioned, if you misuse penicillin, you will teach the microbes to resist it. So we're going to dive straight into this. And the objectives of our meeting today, we'll have a case presentation, both of respiratory tract infections and urinary tract infections, a review on the antimicrobial resistance burden and the role of pharmacists. We'd like to give power back to the pharmacists, because this is their area of specialization that we have actually borrowed from them. Why this matters? Why is it important that we discuss this first case? Okay. Many people attribute persistent coughing, fatigue, or shortness of breath to aging, seasonal allergies, or lack of exercise. And I'm sure you've seen most of these presentations in the last 2 months with the cold season. Ernest, being a 42-year-old male, mistook a cough for influenza. For months, relied on over-the-counter medication and home remedies. Unaware that his health was slowly deteriorating into something more serious, over chronic pneumonia. So why is this important? And I'd like someone in the chat to tell me, have you seen anyone with a cough today? I'm sure you've seen someone in a cough today. There was someone from Aga Khan Kitengela. Have you seen anyone with a cough today? Okay. So it's important that every time you see these patients with a recurring cough, do not brush it off, okay? Don't just think of it as a seasonal flu. Don't discharge these patients with a cough syrup from your shelves, okay? So what happens next? One day he wakes up, unable to get out of bed. His entire body feels weak and drained. The patient still continues to assume that it's malaria. He takes antimalarials. What is actually more serious? And finally, when he goes to the hospital, where he's then informed that he has pneumonia that has progressed to an advanced stage, a chronic stage. Upper respiratory tract infections and antibiotic resistance, okay? 1 in 3 women develop, urinary tract infections. 1 in 3 women develop a urinary tract infection by their 24th birthday. 50% of women will have urinary tract infections in their lifetime. And 20% of all antibiotic prescriptions are for urinary tract infections. I can tell you for free that I've seen 5 patients today with a urinary tract infection compared to the usual hypertension and diabetes in the clinic. So it's important that we have the correct antibiotic treatment for urinary tract infections, often empirically, because in our current setting, our urinary cultures take 3 to 4 days before they come out, okay? Remember, when these patients present to your institutions, to your pharmacies, and they give you the symptoms that I'm having this itchy discharge or I'm having dysuria, don't just be quick to give any antibiotic. I know we love levofloxacin. You take a single dose for 5 days, when you can just start with your ciprofloxacin. And because of that misuse, we're going back to an old drug. Now we're using doxycycline, even for our urinary tract infections. So remember, antibiotic overuse and misuse promotes the development of antibiotic-resistant strains. Okay? So where was this missed opportunity in this 42-year-old woman? She presented with a burning sensation, increased frequency, urgency, which was suggestive of a urinary tract infection. Believing that it was minor, she self-medicated, took a ciprofloxacin from a family member's prescription, self-medicated with over-the-counter urinary alkalizer, and she thought it would be fine. Symptoms improved briefly, so she stopped the antibiotic only after 2 days. So real quick, I'll be checking in the chat. How long should you be taking your antibiotics for your urinary tract infection? You can just put it up in the chat. James, are guys putting it up in the chat?
Yes, the chat is very, very, very busy, Doc. 7
Okay.
days, 5 days, 7 days, 5 to 7 days. Yes.
Okay.
So
What
the
would you...
response is very good. Yeah.
Okay. Then additionally, and this goes to the pharmacists because they're the point of care to these patients. What is your choice of antibiotic for this patient? 42-year-old woman. It's okay. You can put it down. Ciprofloxacin, levofloxacin, ceftriaxone, 2 grams start.
Yeah, Doc, they are coming up. So there's a nitrofurantoin, cefixime, nitrofurantoin, yeah, cefixime. penicillin as first line, norfloxacin, yes.
Okay, no one is using amoxicillin. So why does this matter and why is it important? Over the next 2 weeks, the symptoms recurred with greater intensity, including suprapubic discomfort and foul-smelling urine. Despite persistent symptoms and advice to seek medical care, she continued self-treating and delayed visiting a physician because of her work commitments. Later, she developed a fever, chills, nausea, flank pain. Okay? So we've moved from a simple urinary tract infection to now a complicated urinary tract infection. Okay? What then happens? What is the consequence of this? She presented to the emergency department with a high fever, hypotension, severe flank pain. So our patient has a systemic process now. We're now dealing with sepsis from a urinary tract infection. Investigations at the time confirmed that she had acute pyelonephritis with sepsis with the urine culture that grew ESBL producing E. coli. She required hospitalization, intravenous antibiotics, and supportive care. Imagine this patient presenting to you. Antibiotics just for 3 days. Proper antibiotic use. The correct antibiotic, the correct duration, correct empirical treatment, which would have costed her less than 1,000 shillings, has now pushed her to require hospitalization, intravenous antibiotics, and supportive care. Remember, her initial concern was her work commitments, of which now, since she's hospitalized, she cannot achieve those work commitments. Clearly, this case illustrates how self-medication and inappropriate antibiotic use delayed treatment of a simple UTI, leading to resistance, complications, and hospitalization. And in our setting, such a patient goes to HDU. And for those who have been here, you can appreciate that our HDU is not 2 shillings. Okay. Self-medication and antimicrobial resistance in Kibera, one of our slums in Nairobi, was noted to have a range of 87 to 90% of residents reported recent antibiotic use without prescription. And this happens a lot when you actually visit these areas. Antibiotics are often used to treat non-bacterial illnesses such as a common cold, flu-like symptoms, and mild fevers. Commonly misused antibiotics included ampicillin, cotrimoxazole, tetracycline, and metronidazole. I know metronidazole is really one of the medications you use when patients just present with a diarrhea. You'd quickly give it. Ampicillin, we give it because someone has gotten a boil on their nose. Okay. How many of you have given out an antibiotic for a cold this season? It's okay, don't worry. Your secret is safe with me. A sore throat, a runny nose, ringing in the ear, an itchy throat. Okay. So, frequently sold over the counter or in formal drug shops or kiosks without dosage guidance or diagnostic confirmation. We usually have it there. So, in the last 12 months, antibiotic use alone was at 89%. For those who came for antibiotics with no prescription, was 72%. We had individuals who believed that the antibiotics could treat a flu or common cold was at 70%. No guidance on the use was at 55%. Those who started a course of amoxicillin and then stopped was at 60%. Your leftover antibiotics that was stored. And I'm sure we could even have another category where none of them were confirming the expiry date of these antibiotics. So the key challenges in upholding antimicrobial stewardship: definitely have a high patient workload in the clinics. We'll not start asking the duration, the presentation. For our patients who come in with diarrhea, how often do we ask if there's blood in diarrhea? How often do we ask if they've had a buffet? How often do we confirm the sputum produced in these patients when they're having a cough? So again, that points us to the second part: difficulties in addressing the patient's concern regarding the prognosis. Remember in our initial two presentations, patients want quick fixes. They can't come to the clinic because they have work, they have duty. Unavailability of recommended home remedies such as lemon, turmeric, and honey, which have become quite costly. So imagine buying lemons at 50 shillings compared to having an antihistamine at 10 shillings. I would take the antihistamine at 10 shillings. Honey is 890 shillings. Your antibiotic dose is approximately 200 shillings for a dose. And then easy availability of antimicrobials without prescriptions at local chemists. Now this boils down to you. You are the custodians of these antimicrobials. And even as I talk to you, you are seniors in this field. So remember, every time you give an antibiotic without a prescription, you're indirectly killing this patient. Okay? And that's why this becomes important in your stewardship of antimicrobials. Okay? For the treatment of urinary tract infections, immediately after 24 hours, our patients feel well. Some of them don't even finish the 3-day course of ciprofloxacin. So the first thing is patients fail to finish their treatments. Some of them have the confidence to share their medication with families. For those who have seen patients with sexually transmitted infections, they usually ask, can I share this dose with my spouse? Can I share this dose with my girlfriend? Or if I have 2 girlfriends, can they take 3, and then we'll both be fine? So it's good to actually take your time with these patients and explain why they cannot share their medications and why the number of tablets is specific for them. That brings us to number 3, failure in explaining about the disease and perceived dissatisfaction with care provided when antimicrobials were withheld. For those patients presenting with a sore throat during this cold season, not all of them need to go home with an antibiotic. You can tell them to do home remedies, see them after 2 days. The pharmacy will still be there. By God's grace, you'll still be there. And you can give adequate delivery of health to these patients. Lastly, often relied on non-prescription based antimicrobials from local chemists and private clinics. I know by the time a patient comes to your private clinic, they want an injection. And some of these injections are usually antibiotics. I've been subject to this myself, where a patient walks in and tells me, I want that quick fix. Is it possible to get a ceftriaxone 2 grams? Why? Because I have an itchy throat and I need to go back to work. Okay. So, interventions to reduce antimicrobial misuse should therefore be directed both at the facility and at the community level. And again, you are the stewards at that level. When you look at this chart, the burden of antimicrobial resistance in Kenya, okay, where we have neglected tropical disease and malaria, unintentional injuries, chronic respiratory disease, diabetes and kidney disease, enteric infections, digestive diseases, and then towards the end, antimicrobial resistance. Do you see where we are? 40th highest age standard mortality rate by 2021. Okay. You can appreciate, if you're to compare it with 2010 and 2021, we've had an increase of more than 50%. So remember, as we misuse antibiotics, you're indirectly killing these patients. You're indirectly giving them false hope. Okay. Where we have associated deaths at 29,247 and attributable deaths at 5,805. Remember, as short course, the correct antibiotic can save a patient's life. Additionally, can save their finances. When we misuse these antibiotics that we definitely use in a clinical setting, we delay treatment. We do multiple cultures while practicing gunshot medicine. So remember, even when looking at our infants under the age of 5, every time we give our amoxicillin syrups without getting proper presentation, we're accordingly killing 2,450 children, and those associated with that, 171. We've not broken this down further, where allergic reactions to your penicillin could actually give this patient an anaphylactic reaction in the house, while you advising this patient to seek proper care can be done in a proper hospital setting, therefore saving their lives. And just to absorb this chat a bit, and this is how serious it is, this is how serious our practice is. So still on the same, now specifically, we're looking at E. coli, which is one of the most common causes in urinary tract infections. You see the resistance to cefuroxime that one of you mentioned is at 64%. Ceftriaxone that we love giving as an injection is at 64%. Cefepime at 31%. Meropenem, which is your second line, is at 9%. Ciprofloxacin, because of the misuse, 60%. Ampicillin being the highest at 87%. Gentamicin, 22%. Nitrofurantoin is at 6%. And this is attributed because the dosage of nitrofurantoin requires a patient to take it 4 times in a day, therefore at 6%. And the one that we love very much, ceftriaxone, at 64%. So imagine every time you give that injection, your patient will come back. Your patient will come back with worse symptoms. And even the ones that we give in an inpatient setting, such as piperacillin, is at 27%. So still, a delay in care increases the chances of resistance in these patients. Klebsiella pneumonia. When taking care of these patients, you also practice barrier methods. So look at it. Still, cefuroxime and ceftriaxone, which we commonly use. So our patients will definitely come back. And these patients will end up in the HDU paying more, and some even succumbing to death. Okay. So let's pause for a minute over there. Okay. I'd like to ask a quick question, if you'll allow me to. So real quick. Okay. James? James, are you there?
We are
Yeah,
good. We are
I'm
good, Doc.
here. I can see.
Okay.
You can
So
put it on presentation mode.
Okay. You can see it?
Yes, visible.
Okay, good. So let's see who are going to be you said the first 5, huh?
The top 5 to put the correct answers on the chart.
Okay, let's see.
Yeah.
Name any 2 infections in the upper respiratory tract.
So
Please
Doc,
find.
you can put it on the presentation mode.
You can see it?
The second, kindly share the second slide. The first slide doesn't have the question. Share the second slide, kindly, Doc.
Yeah, there we go.
I think it's not moving.
It's not moving.
I can project it for you, Doc. No problem. You can stop projecting. Yeah.
So.
It's already come.
Doc, you've actually projected it together with the answers.
Which is okay.
Mwakenya imekuja, eh?
Yes. And I can see the chart is very, very hot here. We have Jeremiah Mandara, bronchitis, Alexander, pneumonia, Eunice Mwikali, pneumonia, bronchitis, pharyngitis. Yeah, David Keegan. I think I've seen your name a couple of times. I'm sure you've you scooped quite a number of prizes from this session, and this is quite encouraging. Back to you, Doc.
Okay, good.
Yeah. So
pretty much this also shows the resistant trends to Acinetobacter. So these resistant trends would not be important if you don't understand the stewardship process. It's okay to say no. It's okay to put life before profit. Okay. Similar presentation for Pseudomonas. You see your cefepime is there at 21%. Your meropenem, your second line, is at 35%. Ciprofloxacin at 29%. And then your third line, piperacin, is at 31%. And this was just last year. Salmonella, ciprofloxacin is at the lowest, with ampicillin being the highest resistance at 19%. Ceftriaxone, we didn't have any resistant pattern. So it's prudent to appreciate carbapenem resistant Enterobacter and extended spectrum lactamase producing organisms, which has a poor clinical outcome, in invasive infections are increasingly prevalent in Kenya. And these patients are more in the lower socioeconomic class. Okay. A recent study found that 7 to 17% of hospitalized patients have infections caused by these bacteria, with 39% of isolates meeting the difficult to treat resistance definition. Like I said, remember our urinary tract infection. 3 days versus 2 weeks and hospitalization in the HDU unit because of sepsis. And this is a concern that we should address. So, the economic impact of gastroenteritis alone was 46% in children hospitalized, while pneumonia was at 28%. Antibiotic-resistant infections occurred in 27% of these participants, while there was an increased mortality of these patients by 1.4, longer hospital stays, 60%, higher treatment costs, 33%, which is very important right now in the Kasongo area. So what is antimicrobial stewardship to you? And this refers to a set of commitments and activities designed to optimize the treatment of infections while reducing the adverse events associated with antibiotic use. So for every pharmacist looking at this right now, remember that it is your duty to guard your antibiotics. It is your duty to guard the antibiotics, correct antibiotic use. It is prudent for you to correct your patients and tell them, no, start with this one first. Let me see you after 3 days. Your cough, tell me more about your cough. Is it a dry cough or a wet cough? Do you have a runny nose or not? Is the sputum yellow or is it tinged red? Tell me more about your diarrhea. Is there blood? For how many days have you had it? Do you have a fever or not? It is prudent to always reassure your patients as well, and this is part of the stewardship process. The goal, the right drug, the right person, and the right time frame. I saw for your urinary tract infection, some of you are treating for 7 days, 5 days, 10 days, 14 days. Some would even treat for 21 days. But remember, the right drug. And when we want to talk about the right person, what's the difference between male and females when treating for a urinary tract infection? How long should women be treated for? How long should men be treated for? James, can we hear from you?
Hi, Doc.
Yes.
You want me to give it a try, or I check how guys are?
Check how guys are doing for males versus females.
As I also give it a try.
Yes, give it a try, James, so that the doctors don't cheat you.
Okay, I can see that we've not gotten anything from the chat. Let me give people 1 minute. So
Okay.
Rosemary, longer for women.
Yes, Rosemary. When you say longer for women, how many days for women? How many days for men? We have guidelines for that.
Okay.
Okay, we can see the answers coming. Rosemary, longer for women. Rosemary Shikanda. So let's get our answers, guys. So let's continue typing our answers. Eunice Mwikali, is saying 5 days women, 7 to 10 days men. Jepkemoi Chesarem is saying that they're the same. Rogers Motevia, 7 days for men, 5 to 7 days for women, 1 to 3 days for men. Vincent Mose, 5 days for men. So, Doc, I think averagely most of the people are leaning towards 5 to 7. 5 to 7 actually seems to be
5 to 7
taking
days.
the 5 to 7. Yes, let's work with that.
Okay.
I'll give it 10 days for men.
10 days for men.
Yes.
So for women, in our urinary tract infections, we do 3 days. Okay. For men, we do 7 to 10 days. This is because when talking about women, it's uncomplicated urinary tract infection. While for men, we do not expect them to have any microbes within the urethra. So theirs is 7 to 10 days, therefore being a complicated urinary tract infection. So therefore, if you underdose all these patients, I'll be having a lot of work coming next week. So right drug, right person, and right time frame. So what are the goals? Primarily, optimizing clinical outcomes while minimizing unintended consequences of antimicrobial use, such as toxicity, selection of organisms, and emergence of resistant strains. You remember
Hi,
the...
Doc.
Hi.
Kindly put your slides on presentation mode. They're not moving.
So moving again?
Now we are good. Now we are good. We can proceed.
Okay, good. You remember in 2024, we had super gonorrhea that required inpatient management. And this was because of the wrong antibiotic use and the wrong duration of treatment and poor follow-up of these patients. The secondary goal of antimicrobial stewardship is to reduce healthcare costs without impacting the quality of care adversely. Okay. So looking at these 7 core elements of antimicrobial stewardship, we need leadership support. We need accountability, drug expertise such as yourselves, actions to support optimal use, tracking and monitoring of antibiotics, prescribing use and resistance, reporting information to staff on improving use and resistance, and education as we're having right now. I pray we'll get to a point where we can track and monitor antibiotics the way we track and monitor misoprostol and mifepristone in our pharmacies. Okay. That being said, the 5 Ds of antibiotic stewardship: proper diagnosis with evidence-based guidelines. Drugs. What is the most effective drug for our patient presentation? The dose: 625 milligrams versus 1 gram of penicillin. The duration: 3 days versus 5 days versus 14 days. And then, am I at a point where I can de-escalate the antibiotics? Can I review this patient after 48 hours? Can I review them after 72 hours? Can I review them after 24 hours? Is it okay with a single dose? So all these are important for you. Still repeating the same, the CDCs of 7 core elements of antibiotic stewardship: leadership, accountability, drug expertise, action, tracking, reporting, and education. Still there. Pharmacists are important in this. We have a charge nurse, infection preventionist, medical directors, your EHR, residents, consultants, leadership as well. So pharmacists are part of this chain of antimicrobial stewardship. So what is your role? Pharmacists play a central role by managing pharmacotherapy across multiple clinical practice domains. Additionally, in audit and feedback to surveillance of antimicrobial consumption and outcomes, diagnostic stewardship and educational interventions represent the core strategies where pharmacists optimize antimicrobial use. I'm sure in your stations where you are, you actually call up doctors and tell them the dose they've given is too little, the duration is too short, the dose they're giving is associated with adverse effects. So Pharmacists are core in antimicrobial stewardship programs. They additionally conduct structured risk assessments and monitoring drug-specific toxicities that can enhance treatment safety. They equally provide support, infection control, practice through disinfectant management, outbreak response, and post-exposure prophylaxis. Again, breaking it down, physician leaders with ID training, pharmacists can do that, co-lead by pharmacy leader with drug expertise and ID training, clinician and heads of departments, infection prevention or hospital epidemiologists, quality management of staff, microbiology lab, IT staff, and nurses. Each and everyone play a specific role. So while looking at this, it's important that pharmacists, together with consultants, together as their head nurse, together the IT staff, equally come together in ensuring that the antimicrobial stewardship is achieved. Still the same as we continuously break it down. Okay, so consistent public education and awareness. Antibiotics are not always the right answer. And I want you to preach this gospel during this cold season. Antibiotics are for bacterial infections and not viral infections and will not elevate viral symptoms. Azithromycin does not shorten the duration of a viral pneumonia. Azithromycin does not relieve the cough. Some infections might improve without the antibiotics. The reason an antibiotic is being used and how to properly take it to ensure the drug has the best opportunity to cure the infection. Taking antibiotics when not clinically necessary may lead to unnecessary side effects, antibiotic-resistant bacteria. Remember, azithromycin can also give you azithromycin-associated diarrhea. So do not misuse it. Levofloxacin, which is a second line in TB treatment, do not misuse it when a patient reports that they've not recovered from their urinary tract infection. Okay, so this is a nice table that shows us clinical situations and where antibiotics can be stopped. Your respiratory tract syndromes, your viral pharyngitis, your viral synovitis, your viral bronchitis, non-infectious cardiopulmonary disorders misdiagnosed as pneumonia, your acute otitis media in your under fives, skin and soft tissue infections, subcutaneous abscesses, lower extremity status dermatitis. It's okay when the girls come and they have those presentations on their lower limbs. Reassure them, do not give them antibiotics. Asymptomatic bacteria and pyuria, including for catheterized patients. You do not need to give all your patients who present to the unit antibiotics. If I may ask, how do you make a diagnosis of a urinary tract infection? You just need 3 things to make a diagnosis of a urinary tract infection on your urinalysis. Could I see them on the chart real quick as we move along? Microbial colonization and counter contamination, and low-grade fever. Okay. Your duration of therapy. For community-acquired pneumonia, 5 days, which would beg the question, why would you do it for 14 days? Healthcare-acquired pneumonias, 8 days. Skin and soft tissue infections, 5 days. Your urinary tract infection, cystitis, 3 to 5 days. Pyelonephritis, 5 to 14 days. Catheter-associated, 7 days. Your Staphylococcus aureus bacteremia, low risk of complication, 2 weeks. High risk of complications, 4 to 6 weeks. Your intra-abdominal infections, 4 to 7 days. Your surgical antibiotic prophylaxis, 1 dose. How many of you call your consultants to ask why they're using 3 doses for surgical antibiotic prophylaxis? I'm sure most of us don't, and some of us lean on the aspect of its hospital policy. However, we have guidelines to protect these patients. We have guidelines to ensure that our patients do not incur unnecessary costs. We have guidelines to ensure patients do not have a longer hospital stay, and also for them to avoid adverse effects of the drugs we're giving them. So, pharmacists, facilitating the proper use of antimicrobial agents. supporting infection control and prevention, the management of antibiotics-related adverse effects. Pharmacists are very important, and I will never get tired of saying this. And I call my pharmacists to ask and share ideas depending on my patient's presentation and which antibiotic would be the best. So again, I'm just reminding you of what you do every day better than I do. So, responsibility to reduce transmission of diseases is actually the role of the pharmacist, where you participate in infection prevention and control committees, establish pharmacy policies and quality control programs to prevent contamination, encourage use of single-dose packages over multi-dose containers. Remember, when patients see a lot of drugs, they might not take them all. And a patient would prefer a single dose of 1 gram azithromycin compared to your amoxicillin taken for 7 days. Recommended proper labeling, dating, and storage of sterile products, which is very important. Promote routine immunization for staff and others affecting patient care. This fifth one is a bit tricky. For pharmacists, how many of you actually encourage people to take up the flu vaccine this year? Or the COVID vaccine 5 years ago? If it doesn't start with the pharmacists, then people will not follow suit. Enforce adherence to standard precautions in patient care environments. Collaborate on guidelines for risk assessment, treatment, and monitoring of infectious contacts. So, your responsibility for optimal use of antibiotics would want a multidisciplinary approach in our patients. Collaborate with the lab staff to ensure timely and appropriate testing for these patients. What was their presentation? Which urine was picked? Morning urine, midstream, or last? Participate in P&T committee or equivalent to ensure availability of appropriate antimicrobial agents. Operate on the antimicrobial stewardship program that uses patient outcome to evaluate policy effectiveness. When we give ceftriaxone alone for our patients with STIs, which organism are we missing? Really quick on the chart. And that's why it's usually given as a combination of ceftriaxone and azithromycin. So which one are we missing when we give ceftriaxone alone? So pharmacists also generate and analyze quantitative antimicrobial use, data for outcome and assessment. The use of the information technology to enhance stewardship via surveillance, facilitating safe medication management practices, compiling and distributing susceptibility reports at least annually. Okay. So back to my question of the STI, which is really important, and these patients come in after visiting pharmacists. When you give ceftriaxone alone, which organism are you missing?
Doc, I can see the answers flowing. E. coli, chlamydia, there's a fungal yeast, anaerobes. Yeah.
So it's really important, and I appreciate that you actually know which organisms you're missing when you're giving ceftriaxone alone. So encourage your patients to have a full course as per the guidelines. Okay, your ceftriaxone, your azithromycin, and your doxycycline. So the key to success of stewardship programs: clear aim and vision that stewardship is a patient safety priority. Management support and accountability. It's a multi-professional approach with strong influential clinical leaders. An effective communication structure, evidence-based stewardship interventions and plan measurement, education and innovation, ensuring early and short-term wins, and then consolidating the success and gains. So let's summarize it real quick. Respiratory tract infections and urinary tract infections are frequently self-managed, often leading to delayed diagnosis, inappropriate antibiotic use, treatment failure, and serious complications such as chronic pneumonia, pyelonephritis, sepsis, and death. In Kenya, as you've seen, 90% of antibiotic self-medication is common. Misuse includes the antibiotics for viral illnesses, your cough, your runny nose, incomplete treatment in patients with urinary tract infections who feel well after the initial dose, sharing of medications, and easy to access over-the-counter medications. So, it is a substantial public health threat in Kenya as we speak. So, core principles: the right use of antibiotics. Pharmacists and pharm techs play important roles in controlling misuse of antibiotics and auditing prescriptions. Pharmacists and pharm techs collaboration with clinicians, microbiology laboratories, nursing, and hospital leadership to improve prescribing practices and patient outcomes. Successful antimicrobial stewardship programs require leadership support, multidisciplinary teamwork, continuous education, measurement of outcomes, and clear accountability. Okay, so takeaways from this presentation. Pharmacists are important in the management of antimicrobials in all aspects of care, be it in the clinic, be it in a level 3, level 1, level 6, they are important. Pharmacists are primed to evaluate literature and make recommendations on antimicrobial selection, dosing, and duration. It is important for pharmacists to be aware of national guidelines, national and local resistance patterns, clinical diagnostic tools, and culture data. Additionally, pharmacists can discuss evidence-based medicine with regard to duration of therapy and risk for multi-drug resistant organisms. Antimicrobial stewardship in the community and hospital settings is of utmost importance for helping combat the antimicrobial resistant crisis. So thank you for your time. So we can get into the Q&A.
Thank you so much, Doc. That was a very informative session. I believe and I hope that as members we've learned a lot, and especially on this antimicrobial stewardship. So straight up, we are going to move to the next session, which will be product presentation. After the product presentation, we will be proceeding to the Q&A session. So I'm actually urging members to continue stick around with us. More questions are going to come, so still more awards are there to be won. So keep tight. Let us proceed. So allow me to welcome once again the Sun Pharma presenter, Karibu Sana. Let's do this.
Hi,
So
Dennis.
James
I
Mbogo.
think, thank you, Dennis. Doc, you can allow me to present kindly. And I think as I present today, Dennis, I've seen we've hit 1,000 participants mark. I don't know what you did for this session. The participation has been very good, and before people start dropping, we have another chance to earn some good airtime. I'll do 2 questions now and 2 questions at the end of the product presentation. So, and we go straight into it. Which are the 2 strengths of enhancing Kenyan market? And Doc has talked about antimicrobial stewardship. And the key thing I've come out with is you cannot use an antibiotic to clear a viral infection. So which are the 2 strengths of enhancing we have in Kenya? And I hope the answers are flowing well, Dennis.
Yeah, correct. We are getting actually the answers are flowing very well. So thank you, participants. Let's continue answering. So Susan Wesonga, Millicent, 625 and 1 gram, Wilson, Sylvia Motunga, Daniel Kilu. Clearly, members have actually been using Sun Pharma products. Enhancing actually seems to be a very popular brand in the market. 1 gram, 625, Jamila, Anastasia, Cosmos, Unisodera. So I think James, from the look of it, most of the members are actually privy with the strengths in the market. So attached there on your screen, those are the answers. So we can proceed to the next one.
Thank you very much, Dennis. So the second question is, what is the flavor for Brewston syrup? One of our brand for pain and fever.
Okay,
What is the
Dominic,
flavor for
there,
Brewston syrup?
Gabriel, orange, 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 lavender, Pamela, Anthony Mosioki, Charles, Beth, Nancy, Mohammed, Lona, Ochanda, Jacqueline, orange, 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 and I believe CODM in orange, orange. Oh, thank you, guys. Thank you, guys. I think,
Okay.
James, that is well tackled. So let's proceed.
So the flavor for Brewston syrup is peach and peppermint, and which makes it very palatable. So Dennis, I think I'll just proceed to the product presentation.
That's in order.
I will take less than probably 5 to 7 minutes, and then we'll do 2 more questions, get to the Q&A, and then finally I'll call Bernard to come and announce the winner. So guys, don't drop. So just to look at Sun Pharma at a glance. So we are in more than 100 countries globally, diversified business, innovative medicine, branded generics, fastest growing, 13th generic company in the US, the largest pharma company in India, and emerging markets. Looking at some of the leading brands for Sun Pharma in Kenya, we have Lanferon, our brand blood builder, and Brewston, our brand of ibuprofen plus paracetamol. How about Kenya? So where is Sun Pharma in Kenya? We are the 5th company, Kenya pharmaceutical market, fastest growing company among the top 10, number 1 in psychiatry and neurology, 3rd in cardiology, 13 therapy areas across different portfolio with 65 products. Last year, we managed to reach 47,000 patients through different patient care initiatives. And among them was spreading disease awareness. During the World Heart Day, we reached 1,000 lives. During the World Diabetes Day, we reached 1,000. And during the World Mental Health Awareness Month in May, we reached 500. And in our quest to make Kenya anemia-free Kenya, we have anemia-free Kenya initiative, where we conducted more than 400 HB camps, tested 43,000 patients, 24,000 were diagnosed, and we offered treatment to 23,000. And we are joining efforts towards making Africa anemia-free. Then for patients with epilepsy, for our neuro portfolio, we helped more than 600 patients to gain victory against epilepsy through this just diagnosed kit that has different items inside to help the patient overcome their challenge with epilepsy. These are some of the therapy areas that we are in as Sun Pharma. And then Doc has talked about proper antibiotic or antimicrobial stewardship. We have our brand of enhancing. And today we are saying together we are enhancing the world. Enhancing offer you quality, dual power, trust, and precision. And as the pharmacist, some of the key indications that you usually find at the pharmacy before this patient sees the doctor, before this patient get even the testing assessment, they come to the pharmacy. So in tonsillitis, sinusitis, rhinitis, otitis media, pharyngitis, we offer you enhanced quality and sure success. And enhancing is actually recommended as first line in treatment for acute pharyngotonsillitis in adults. And the dosing is 625, 8 hourly or BD. So our enhancing has demonstrated excellent efficacy and safety profile in treatment of this upper respiratory tract infection. Then in severe upper and lower respiratory tract infection, enhancing has activity with less chances of recurrence. And in this case, we are talking about 94% clinical success rate in CAP and 93% clinical success rate in acute exacerbation of chronic bronchitis. Again, in addition, enhancing demonstrated 97% bacteriological eradication in CAP and acute exacerbation of chronic bronchitis, with 50% less incidence of adverse event like moderate to severe diarrhea. So for this, I'm just calling you out. Recommend enhancing to your patient with this lower and upper respiratory tract infection, where the causative agent is a bacteria, not a viral. As Doc said, we have to stand to be at the front line of this antimicrobial stewardship fight before things go south for everyone. In addition to this, Sun Pharma has Lanferon, the blood builder for the family. And what we are saying here, the importance of iron supplementation in children for our Lanferon syrup. It relieves fatigue, improve motor skills, concentration, and attention. WHO recommends daily iron supplementation for 3 consecutive months in children over 60 months. Anemia in school-age children can affect motor performance, cognitive function, and educational achievement. So recommend Ranferon for stronger children and for the stronger future. So we say for treatment and prevention of iron deficiency anemia in children, we offer you Ranferon syrup. Then we have Brustan, one of our big brand. In the world of Brustan, everybody can actually get back to the rhythm. That is what we are saying. So Brustan offer rapid action, effectively reducing fever within 23 minutes, which is faster than paracetamol alone. So Brustan, our brand of ibuprofen 100 mg with paracetamol 125 mg per ml. So, and that is basically communicating to you why Brustan, the combine to combat. It offers faster fever clearance, well tolerated in children, delicious peach and peppermint flavor, as we said, for better palatability and better patient compliance. In addition to this, when it comes to pain putting the brakes on your life, is pain putting the brakes on your day? So we offer to you Volini, and we are saying here, pain relief starts within 2 minutes. And what type of pain are we talking about? We are talking about low back pain, joint pain, muscle pain, sprain, and strain. These are actually some of the pain people go. They feel uncomfortable every day without knowing they have it. So we offer you Volini. And Volini present with 4-way action. That is diclofenac for pain, linseed oil, which is our anti-inflammatory, and then resmenthol, which unlocks the cooling effect, and methyl salicylate for the musculoskeletal pain. Again, this year, to just ensure that we offer you quality medicines at accessible prices, we decided to reduce the price of Brustan. Now, Brustan tab at 95 shillings, the suspension at 240 shillings, the Ranferon cap going down by 10% to 350, and the Ranferon syrup going down by 18% to 315. And again, without forgetting Volini at 220 shillings. Yes, I think we discussed and over-discussed Somplaz. We have our brand of Esomeprazole, Somplaz 20, Somplaz 40. And then finally, we again have listened to your recommendation. And now we have Cetirizine, our brand of Cetirizine, in packs of 10s. So I think that is the end of my presentation in exactly 10 minutes. So we will finally we'll go to the final 2 questions. I think Dennis.
Thank you so much. That's so much in order. I think
Yes.
you've done a great presentation. So let's proceed and do the 2 questions before we proceed to the Q&A. So of course,
Yes.
guys, as you can see on your screen, poll question 5. Volini provides 4-way action for pain relief. Name any 2 active ingredients in Volini. So let's go, guys. Top 5 members who will be first to answer. We have an award for you at the end of this session. So we can see John Nzuki, Cynthia, Rebecca, Lemiso. Thank you. Remember, we've said 2, at least 2, not 1. Dickens Ngase, Evelyn Moody, I see you. Willie Lokawa, Isaac Kimboi, Daniel. Thank you, guys. Thank you, guys. That is well sorted. So as you continue to do that, I feel like, thank you, guys. Those are the correct answers there. As you can see, diclofenac, linseed oil, resmenthol, and methyl salicylate. So in case you actually mention any of the correct answers, you stand a chance to win something. So let's proceed to the next question, please. The final question is here. What is the amount of elemental ion in ranferon syrup? So you can actually pick the ranferon syrup on your shelf if you are in the pharmacy right now and type the answer here. Elemental ion concentration, what is the amount? So I can see Kennedy, Jacqueline, Edwin, Kipto, Anne, Lucy, Cynthia, Margaret, Ochanda, Josiah, Susan, 41, 40, 200, 41. Let us see the correct answers. Show me the correct answers. Thank you, guys. So the correct answer, if you actually typed 41 milligrams of elemental ion, then there you go. That's actually the correct answer. So thank you, everyone who has taken their time to participate in this in these polls. That is very, very much appreciated. So let's proceed straight to the Q&A. I'm still expecting your questions on the session which we just had. So I have some few questions here, Daktari. This is actually our session. So I'll take you through some of the questions which I've seen. So in case you still have questions, feel free to type them. Daktari is here to answer them. So Doc, there's a question which one of the members called Maluki asked. Maluki asked you to comment on what's your take on single-dose antibiotic, especially in the management of gonorrhea? What's your take on single-dose antibiotic, especially in the management of gonorrhea? He was actually trying to emphasize on the 2-gram azithromycin. So kindly clarify on that, then we proceed. Daktari Karibu. So Daktari, if you're there. Okay, so as Daktari is coming, there's a question here also for Sun Pharma. Let me read it loud. Just a second. 1 minute. Yeah. So there's a question here for you, James. Can ranferon be taken with calcium concurrently? So are you in a position to answer that, James, as we wait for Daktari to come on board?
Just a minute.
Oh. Daktari, also you can confirm whether you're back.
Yes, I was just reaching to Ruka to maybe check Daktari, whether Daktari is
Okay.
is able. So we usually recommend ranferon to be taken. If you are taking calcium and ranferon, you can take it alternatively. So if you are taking ranferon in the evening, take calcium in the morning.
Okay.
Yeah.
So maybe because of why, you can just expand on that a little bit for members to actually.
Basically, it's because of the iron and the calcium. So we don't recommend them to be taken together. But if you have the two supplements, take one in the morning and one in the evening.
Okay, thank you so much. As we still wait for Daktari, we will continue taking questions for Sun Pharma. There's another question here on Brustan. So a member called Shadrach Mutungi is asking, is Brustan suspension safe in children below 6 months? So James Mbogo, you can take that.
Yes, in a moment.
Kindly combine it also with, there's also another question from Alex Ogola. I feel like you can combine the two.
Yes.
Still on Ranferon, they're asking whether Ranferon best before or after meals?
So yes, Dennis, first of all, Brustan is recommended from 6 months and above. So for children below 6 months, it's not recommended. And then Ranferon is taken after meal. Yeah.
Okay, that is well put. Then, okay, so I think that's in order. So do we have Daktari? Is Daktari back?
Dennis, I'm just reaching out to Daktari shortly.
No problem, no problem. So guys, as you continue to type in your questions, we will be taking them. So I also want to take this opportunity to just reiterate for members who might have joined us late. So there are also members asking whether the event is already on the portal. So the answer is no for now, but it has already been submitted for approval. So we are just waiting for approval. So probably by tomorrow it will be live. So ensure that by tomorrow when you go to your portal, you'll find the event. Ensure that you subscribe. As we were told, the event will be live. We have 7 days to actually claim our points. So make sure that tomorrow when it's live, you go there and you subscribe to the same event as we continuously await for these great webinar sessions. So, so another question for you, James. What is the best dosage of Ranferon? As we wait for Daktari still. Guys, Daktari will be joining us in a few.
Yes.
James, are you there?
Yes, I'm here, Dennis. So, and I've reached out to Daktari. He's coming back. I think he had stepped out a bit. So Ranferon is the syrup is taken is 1 teaspoon for the children, and for the adults is 2 tablespoons once a day.
Okay, I think that's right. So members, I just want to summarize, just to reiterate, from whatever we've learned today on the key awareness, consistent public education or awareness, which we need to abide with. So we've actually learned today that antibiotics are not always the right answer, which means that as we continue to clerk our patients, antibiotics shouldn't actually be the first line of therapy, which we recommend for our clients. We need to diagnose further so that we can be able to see what's next. Then we've also managed to learn that antibiotics are specifically for bacterial infections, not viral infections, and will not alleviate viral symptoms. So let's actually be careful with that. Let's not dispense antibiotics for viral infections. I believe that is actually within our scope, and we will adhere to that. We are also being told that some infections might improve without antibiotics. Hence, if an infection can improve without antibiotics, let's actually consider that route instead of dispensing antibiotics when it's not necessary. So the reason an antibiotic is being used and how to properly take it is to ensure that the drug has the best opportunity to clear the infection. So let's be very, very careful with our antibiotic use and dispensing. Remember that rational use of antibiotic is what we are actually recommending for. So let's ensure that that is actually adhered for. So, Doc, is Doc back, James?
He said he's just sitting. He's setting up his machine. I think he had gotten an emergency.
Okay,
Let
no
me
problem.
just check in a moment.
It's in order,
Yes.
guys. So I'll just be
Yes.
summarizing what we've learned. Remember, we've talked about the 5 Ds of antibiotic stewardship. The 5 Ds basically emphasizes on diagnosis, drug, dose, duration, and of course, de-escalation. So of course, on de-escalation, the narrowest spectrum of drug with clinical efficiency should be used. Drug therapy and patient response should also be reviewed after every 48 hours. So let's ensure that we adhere to such. Otherwise, members, I feel like where we've reached, we've done well. So what we'll do, I believe that we'll be taking these questions, we'll note them down, and we will be sending, as we do emails to you guys, we'll actually be doing responses with the questions which you've actually asked. So I want to take us straight to Bernard. Bernard, please take up and take us, can you kindly give us the winners who've actually won? Uh, in the questions which we had. Karibu sana Bernard.
Thank you very much, Dennis. It's been a very interesting topic in the era of antibiotics and resistance. So this topic couldn't come earlier than this. So I want to appreciate everyone who participated in the poll questions. Quite a number of people who are giving answers. We really appreciate the initiative, and of course, we appreciate the fact that you are keeping our products in your shelves and your counters, and you're recommending them. So the answers to the first poll question, which was talking about any two infections on upper respiratory tract infections, we have John Zuku, we have Felix Wainaina, we have Silas Walifu, we have David Keegan, and Emily Kinis. The second question, which I think was mentioned, was the Amoxiclav brand of Sun Pharma. We have Jeremiah Mandara, we have Alexander Ambeasi, we have Nancy Kosgei, Kennedy Kipum, and Sheila Kitur. These are the people who gave their answers quite fast. And the answer, of course, is the Amoxiclav available as 1 gram and also as 625 is a Nansen. For poll number 3, that is 2 strengths available with the Nansen in the Kenyan market from Sun Pharma. We have Felix Wainaina and John Ziki, Gabriel Njuguna, Helen Nyanjama, and we have Eunice Mwikali, the first people who are able to respond to the poll question on the chat box. Then the flavor of Brewston, I think a couple of us really got this wrong. Of course, Brewston, when it comes to flavor, it's available in peppermint flavor. Of course, that is to ensure that for the kids, the palatability is really improved, and that when it is palatable, it determines compliance. So we have people who really tried, even though they probably missed on one flavor. We have John Zuki, we have Pauline Mwandemba, we have Sheila Kitur, we have Evans War, and we have Eunice Abdule. Then the fifth question, which talks about how Volini is able to work. It is powered by 4 molecules, and we were required to mention any 2. We have the following attendees, delegates who really mentioned the right answers. Sakina Abdullah Rahema. We also have Masi Suge. We have John Zuke. We have Daniel Mutwiri. And we have Rehema Kungula. Then the last question, which was talking about the elemental ion in saffron syrup, which is 41. Actually, when you look at most of the available Imatinic in the market, Ranferon really provides the highest elemental iron. And we have the winners being David Keegan, Dixon Ngase, we have Masi Suge, Rose Mudoka, and Julius Kilonzo. So these are the these are the winners of our poll this day. We want to appreciate everyone who participated, and definitely, of course, what we are saying that pass the benefits of these brands to your patient, be it Ranferon, be it Brustan, be it Enansin, and even Volini, and Sombras 20 and 40, pass these benefits to your patient. Back to you, Dennis.
Thank you, thank you, thank you so much, and congratulations to all our winners today. I believe that this has been such an informative session. So as we bring this incredibly enriching and timely session to a close, I want to express my deepest gratitude to everyone who contributed to making tonight a resounding success. First of all, an extraordinary thank you to our expert speaker, Dr. Hilary Edalia, for generously sharing his profound clinical insights. Thank you so much, Doc, for equipping us with actionable evidence-based tools to champion antibiotic stewardship and improve patient outcome on the front line. So we want to also extend our sincere appreciation to our sponsor, Sun Pharma, for their steadfast commitment to continuing medical education through the SPEAR umbrella framework. We thank them for supporting essential options within our therapeutic arsenal, including trusted formulations like Brustan, Ranferon, Volini, and all other brands which are within their umbrella. Also, a big thank you to KPA, Kenya Pharmaceutical Association, Coast Branch for their collaborative excellence in organizing, driving, and accrediting this masterclass, ensuring our professionals seamlessly advances its clinical roles. Finally, to you and me, our incredible audience of pharmacists, pharmaceutical technologists, or any other healthcare professionals who has actually taken their precious time to attend today's webinar. Thank you so much for your time, for your vibrant engagement in the chats, and your unwavering dedication to rational prescribing. Thank you so much once again. And also, as we close, remember that the webinar will be available on the platform, on the PPB portal tomorrow. Remember to go there and check so that you can subscribe, so that you can actually be eligible to claim your tokens. Otherwise, thank you so much. Asanteni sana. Let's see each other in this next webinar session. Good night and have a nice time.
Bye-bye.
Thank you, everyone.